Good afternoon, everybody. Looking here. Welcome to Cardiovascular Grand Rounds. I just wanted to take a quick minute before we start to go over a couple of announcements. First, if everyone could sign in when you're taking a box lunch, that would be great. We're just trying to keep track of how much to order. And then number two, if you are on our Zoom world, we have disabled all microphones. If you have a question, it's only chat enabled. If you do have video, please do make sure that you are unvideoing yourself in the Zoom world as well. We do not have the ability to do that on autopilot, unfortunately. So welcome to today's talk. We have Dr. Stanley Chetcuti and Dr. Grossman, who are going to give us a joint grand rounds on the TAVR world. Dr. Stanley Chetcuti is a clinical professor of internal medicine and the Eric J. Topol Collegiate Professor of Cardiovascular Medicine, who serves as director of the Cardiac Catheterization Laboratory. He has been in practice for more than 20 years with expertise in treating coronary artery disease, heart failure, heart valve surgery, among other conditions. His research focuses on percutaneous circulatory support systems, novel treatment for acute coronary syndromes, and percutaneous management of patients with structural heart disease. Dr. Grossman is a professor of internal medicine in the Division of Cardiovascular Medicine here at the University of Michigan as well, and a staff cardiologist at the VA Ann Arbor. He is an interventional cardiologist with clinical interest in catheter-based treatment of coronary, peripheral arterial, structural heart, and valvular heart disease. His academic interests are focused on quality improvement in management of peripheral arterial disease and therapeutic angiogenesis. Please join me in giving a warm welcome to Drs. Chetcuti and Grossman for today's talk.
Thanks very much. Wonderful to see so many friends, colleagues in the audience and joining us on Zoom. Stan and I decided that we wanted to sort of give an overview of our program here at Michigan Medicine and then touch on some of the future as it relates to transcatheter aortic valve replacement. We're going to try to do all of that in 50 minutes or less and somewhere just short of 100 slides. So strap in. So these are our disclosures. I'm going to start with just a brief historical background, and to me this is fascinating. The first foray into mechanical treatment of aortic valve disease via percutaneous options was, as most of you know, balloon aortic valvuloplasty. Alain Cribier at the time was recognizing that there were many patients over the age of 70 who were dying with severe aortic stenosis because they weren't being offered surgery at the time. He had been working in the pediatric and congenital world and knew that balloon valvuloplasty, including balloon valvuloplasty of congenital aortic stenosis, was effective, and decided to try that in adults with severe critical aortic stenosis. His first case was performed in 1985. They angioplastied up to a 20 millimeter balloon, and you can see the improvement in the gradient in this patient who actually did incredibly well. His gradients were maintained over a period of years, and he returned to a normal life. And this led to a lot of excitement about balloon aortic valvuloplasty and an explosion in that procedure in Europe and around the world. But pretty quickly, it was realized that most of the patients who received this procedure actually suffered restenosis, recurrence of symptoms. So this wasn't a long-term fix. Then Cribier thought, well, we put stents in kids who have congenital abnormalities, such as coarctation of the aorta and in other places. What if we put a stent in the aortic valve? And this was roundly criticized as absolutely insane. The concern was that you would close the coronaries, rupture the annulus, damage the mitral valve or the left ventricular outflow tract. So the first thing he did was identify patients who were dying or had died of severe aortic stenosis, went to the morgue and got permission to actually blow up stents in their diseased aortic valves. And when autopsies were done, they actually found that there was no damage to surrounding structures and that the stent remained circular. So this led to the idea that maybe we could put a stent in the aortic position as long as it had a valve inside of it, and this would result in a minimally invasive valve replacement. Over the ensuing several years, Cribier and his colleagues worked on this technology. And the first case was actually performed on April 16, 2002. That's Dr. Cribier, obviously. That's the valve. So this is an equine pericardial interannular valve. The patient is obviously in the lower left. This patient did quite well, was discharged in several days after the procedure. Interestingly, this procedure was done via a transseptal approach. So venous access was gained, septal access was performed. They then went through the aortic valve from the left ventricle and deployed the valve, which you can see here in the lower right panel. Look at the faces on the team as they're implanting this and the fear. This is the first time ever done in the world and had a wonderful result. This led again to an explosion of doing these cases around the world. These are some of the pioneers in transseptal TAVR. Bill O'Neill actually did the first transseptal TAVR in North America at William Beaumont Hospital. And the other names on this list are to most of us in interventional cardiology, just the giants of our field. After several years, Cribier was able to sell his technology to Edwards, which is the largest surgical aortic valve company at the time. Edwards developed and expanded the technology. It went from the Cribier Edwards valve, which only came in one size and was horse pericardium, to the Edwards Sapien valve, which we use today, which is a bovine pericardial valve, increased the size matrix, and most importantly, they designed technology so it could be done from transfemoral access, just like a balloon valvuloplasty. There also was a transapical option that was developed, and this was tested over a period of years. There was another device that was being developed at the time, and this used different technology. The metal, instead of a stainless steel, was nitinol, so self-expanding metal, and the valve was different. It was supraannular as opposed to interannular. So a supraannular valve allows better hemodynamics and bigger effective orifice areas, and this was felt to be potentially important for this technology. The first core valve procedure was performed in 2006. This was the world's first pure percutaneous aortic valve replacement using, again, transfemoral access. The case went quite well, and the field was off and running. At Michigan Medicine, we had at the time and still have today an absolutely premier aortic valve surgical program. And our focus of our surgeons, led by Mike Deeb, was to do SAVR in a way that would give the best hemodynamics because it was felt that bigger valves were associated with better long-term performance. Our team chose to pursue TAVR studies that would have a platform that was associated with superior effective orifice area. And we were very fortunate enough to be invited to go to Europe to see some core valves actually being performed in early feasibility studies in 2009 and 2010. Our leaders here at Michigan Medicine supported us to travel to Portugal. Our senior colleague, Sunil Das, reached out to a colleague, Vasco Ribeiro, and we went as a group to see Dr. Ribeiro and meet with Jean-Claude Laborde, the inventor of the core valve, to see some cases being done. Really, we're very excited to potentially be a part of this trial. Almost as we landed, coming back from that meeting, Medtronic purchased the core valve technology, and this led to the first pivotal trial in transcatheter aortic valve replacement using this technology. And again, we were fortunate enough to be part of that trial. One thing that we learned early on from TAVR trials is that they really require a team-based approach to patient care. That means that cardiac surgeons and interventional cardiologists had to work closely together to evaluate these patients and perform the procedures. Not only that, we needed support from multiple different services: cardiac anesthesiology, importantly CT radiology, which is how modern TAVRs are sized, echocardiography, neurology, nurse navigators, advanced practice providers that provide fantastic care both in the clinic and post discharge. We brought together a cath lab team and an OR team. Prior to TAVR, these teams worked in the same building but never worked together. Now we had to bring these teams together to work side by side to do these procedures, and that was a huge undertaking. it was really bringing two somewhat clashing cultures together. We needed support from perfusionists. Inpatient care teams need to be educated about the management of these patients. We've had over the years fantastic research coordinators who have protected us, protected our patients and the institution as we do these trials in appropriate ways, and work very closely with cardiac rehabilitation as these patients are discharged. You need a champion to start a program like this, and Mike Deeb has been that for all of us. He's a leader, he's a mentor, he's a friend and advisor. Mike Deeb had the courage to take on surgeons at not only at this institution, but really around the country to push this technology forward. And as a leader, in in this space, he's been fantastic for all of us. One of the things that was most important is we tried to bring together these cultures was how are we going to all work together? How are we going to do more than one case at a day and have all the members of the team that need to do these procedures come together? And so we worked with engineers to actually design workflows so we could actually bring teams together. Everybody would know their role and be able to perform it simultaneously to do a successful procedure. And this is an outline of what we call our swim lanes for our TAVR procedures. This is a picture of our first team. A lot of friends and colleagues here. Many are still with us. Some have moved on to better opportunities. But this is just probably even a small sample of the number of people that were involved in starting our TAVR program and getting it off the ground. This is our first TAVR procedure. So this is a core valve, the original core valve classic, being advanced over a stiff wire, positioned in a superior way. This case was done with surgical cut down, general anesthesia, transesophageal echo. So we had 20 people in the room for our first case. This is deployment of the valve. You see on the left panel there as the valve is being released. Again, this is nitinol, so it opens as we pull back the sheath covering it, and the valve hits body or blood temperature, it expands. This is an aortogram of the first case. Implant depth is great. We learned after doing a couple of these that you can't have the pigtail as close as it is to this suprannular valve because it hits the valve, causes aortic insufficiency. But on echo, there was no aortic insufficiency. This patient was discharged in 3 days and did quite well. So this is our team. We worked together to build this program. Spent a lot of days and nights together, supported each other. We really worked closely together over many, many years. We've developed fantastic friendships, and we're now fortunate enough to have added to this team. We've added Dan Manise, who is part of not only our TAVR, but our Matrix program. Sarah Galano has been part of our VA program and been leading that. And we're now training fellows annually in our program. So we've really expanded from spending a lot of late night Fridays together to a program that's taking care of a lot of patients. We've enrolled over 450 patients just in the core valve family of studies. Stan's going to talk a little bit more about these in a few minutes. This is our clinical team. They really provide the patient-centered care that we have a true ethos that is focused on. As you probably know, we're required that all patients have a true heart team evaluation. That means cardiac surgeons, interventional cardiologists need to see these patients ideally together. And that's what we try to do here at Michigan Medicine. We also get tremendous support from our imaging partners in radiology and echocardiography. We have a clinic that sees now between 15 and 20 new patients per week. In addition to that, our APPs see at least 40 follow-up patients a week independently. We also perform, and this team performs inpatient consultations, 3 to 5 patients a week, working with the cardiology inpatient teams to evaluate patients who are admitted with acute issues related to aortic valve disease. Our nurse clinical care coordinators help facilitate care, organize care, and provide wonderful communication and education for our patients. And we've been fortunate enough to have a scheduling team that really streamlines the process of getting these patients through the process as efficiently as possible. We meet every Tuesday morning at 7:15 virtually. We discuss cases. It takes about an hour and a half to go through our 20+ patient list. We come up with care plans. These are documented in my chart. And then we talk to our patients and involve them in the shared decision-making process so they can choose the form of aortic valve replacement that's best for them. First thing we ask when patients come to clinic is, does this patient have aortic stenosis? The European Society of Cardiology just put out new guidelines related to valve disease. This is a fantastic overview or algorithm of how to think about aortic valve stenosis. I could do a grand rounds on this alone. I won't bore you with that. But suffice it to say that there are many decision points as we evaluate patients, and not every patient meets every echo criteria for severe aortic stenosis. So you have to put the history together with the echo findings, CT findings, et cetera, to come up with the appropriate diagnosis. The other thing that we really focus on in our clinic, and particularly because we have such a robust surgical program and many of our patients are younger, is the concept of lifetime management. This means that aortic valve stenosis is not a one-off condition that we can treat and the patients will never need to be managed again. So we talk to our patients who are younger, say less than the age of 50, maybe with congenital disease, about potentially a Ross procedure. That is very effective, but there are technical complexities. Our cardiac surgeons have perfected many of these and have wonderful outcomes. Ages 50 to 60, these patients are most likely to be considered for a mechanical aortic valve. However, the downside, as you know, of a mechanical aortic valve is patients need long-term anticoagulation. They have an increased risk of embolic phenomena and hemorrhage as well. And then any patient over the age of 65, we evaluate for TAVR versus a surgical aortic valve replacement. And this is where we really talk about what are the best treatment options for those patients. Any tissue valve has a lifespan of about 8 to 12 years. So we need to take that into account as we're talking to our patients who may be in their late 60s, early 70s with no other comorbidities. These are some of the things that we consider as we're thinking about SAVR versus TAVR. Again, these are the European guidelines, but they're now essentially are mirroring the US guidelines. But again, the risks of a redo TAVR in many of our patients versus the potential of getting a surgical valve replacement, potentially with a root enlargement that then would facilitate TAVR in the future, are things that we talk about with many of our patients. We now are utilizing artificial intelligence to help us facilitate some of these conversations. So we're uploading our CT scans to this company called DASI, and they're giving us what's called a lifetime management report. So we tell them we want to put a 34 valve in this patient today. What will happen if we put a second TAVR valve in the same patient 10 years from now? And this can be modeled. So this is that second TAVR valve inflating. And you can see that the coronary arteries still will have excellent blood flow with a second TAVR valve. So in this patient, a second TAVR is potentially feasible without any need for leaflet modification. These are some of the numbers we get, modeling different valves. So again, we can use this to inform our conversation. What about after the TAVR? These are some areas that we involve many of you in, and we think about every day when we're doing TAVRs. First of all, rhythm assessment. New pacemaker requirement after TAVR is between 5 and 10%. Pre-existing conduction abnormalities or developing a new left bundle branch block after TAVR probably at least doubles the risk of requiring a permanent pacemaker. So any patient who has either of those conditions goes home with a real-time monitor for at least 2 to 4 weeks. In addition to that, we're very concerned about stroke, which may be the most feared complication for most of our patients. The stroke risk is 1 to 2% in the published literature. Our team in the post-procedure area not only performs neurologic assessments on a regular basis as the patient recovers from anesthesia, but if they have any concerns, they're empowered to immediately call a stroke code and get neurology involved without calling me who as the operator may wish a complication away. So this is very important in recognizing stroke and getting appropriate care for these patients. All patients get a post-TAVR echo the day after their procedure. This serves as the new baseline for the patient to which we will compare future echoes. Our patients in our program get a single antiplatelet therapy, usually clopidogrel in our program. Unless they have a need for dual antiplatelet therapy or an oral anticoagulant, then they obviously would get that. All patients are referred to cardiac rehabilitation. Outcomes with patients who do early cardiac rehabilitation after TAVR are excellent. Unfortunately, only about 40 to 50% of our patients who are referred actually go to cardiac rehab. And that's true across the PCI world, cardiac surgery world as well. We're very involved in trying to improve that number because the outcome benefits are undeniable. Our patients get a phone call at 7 days from our team, making sure there are no issues and questions are answered. They come back to clinic at 30 days where they get a full assessment, an echocardiogram, and fill out a quality of life questionnaire. This is again CMS mandated. And then come back to clinic at 1 year again for an assessment, an echo, and a quality of life assessment. After that, long-term follow-up is referred back to the patient's primary cardiologist. And this is where it's very important that we understand that the guidelines for TAVR recommend an annual echo. And why is that? Because we're still very concerned about bioprosthetic valve degeneration and potentially leaflet thrombosis. If on follow-up echo, we see an increase in gradient of 10 millimeters or a mean gradient greater than 20, we need to consider HALT. We need to consider bioprosthetic valve degeneration. These patients should be referred back to TAVR or the multidisciplinary valve clinic. If patients have any new or increased aortic insufficiency, again, we're worried about bioprosthetic valve degeneration and or endocarditis. I'm going to switch gears just a little bit before I hand the baton over to Stan and talk to you a little bit about something else that we're very proud of in the state, and that's engaging our state in quality improvement around TAVR. As you probably know, Blue Cross Blue Shield of Michigan has been very involved in supporting many quality improvement collaboratives across the state in medical and percutaneous and surgical interventions. And we now have what's called the Michigan Structural Heart Consortium, or MSHC, that's supported by Blue Cross Blue Shield of Michigan. All 31 hospitals in the state that perform TAVR, that's right, 31 hospitals in our state now do this procedure. Over 160 cardiologists are participating in this program. We collect data on over 3,000 cases a year, and that's probably accounts for over $140 million in healthcare expenditure just for this one procedure. We collaborate. So MSHC is a collaboration between the Michigan Society of Thoracic and Cardiovascular Surgeons Quality Collaborative that's really focused on cardiac surgical outcomes and thoracic surgical outcomes, and our own BMC2 collaborative, which is focused on multiple percutaneous cardiovascular interventions and vascular surgery. We're now celebrating our 10th year of quality improvement for TAVR in the state of Michigan. And here's a map of all the participating hospitals. So essentially every hospital in the state now that does cardiac surgery has a TAVR program. We've done a few things over the years and focused on a few things. One of the most important is decreasing the rate of transfusion. Transfusion, as you know, in surgery, in PCI, and we also know in TAVR, is associated with adverse outcome independently. What we've seen over the years is not only because of an improvement in technology, but we feel because we focus on this as a quality improvement goal, we've seen transfusion rates drop over time, and the transfusion rates in Michigan year over year are better than the transfusion rates in the national registries. And we do this through working together at our in-person meetings, our online meetings, setting quality improvement goals and sharing best practices. Another thing that's highly associated with adverse outcome is acute kidney injury post-TAVR. Sarah Galano led this work, which found that in our state, AKI more than doubled the risk of mortality at 1 year in this population. And again, this was independently increased risk. So we again focused on how can we in the TAVR decrease the risk of acute kidney injury. And it turns out, not surprisingly, that the more contrast you give, the higher the risk of acute kidney injury. So if we could limit contrast dose, and in this analysis, we found less than 2 times the GFR dose of contrast was associated with significantly lower risk of acute kidney injury. That is now a best practice. It's practiced across the state, and in our own institution, we give the 2 and 3 times contrast dose compared to GFR and shoot for contrast loads less than that in all of our cases. Again, this was the focus of the article, the drivers of acute kidney injury were having PAD, prior PCI, and having a low GFR. But if we could give less contrast, that was associated with significantly less risk of AKI. Finally, just a couple of minutes about stroke. So stroke, again, is the most feared complication of TAVR. The trials would suggest that the stroke risk is around 2%. When we looked at our data at Michigan, we found a huge variation in stroke risk. Some hospitals had no strokes year over year. Others hospitals had 3% stroke rate. And we were trying to understand why, and our data auditors noticed that many patients in some institutions, particularly ones where they weren't seeing any strokes, were not documenting any neurologic evaluation before or after the TAVR procedure. So this led to us to think about why. Well, what we found was hospitals that were certified or comprehensive stroke centers, or CSCs, had trained all of their team members to evaluate for stroke, and all those team members were empowered to activate a stroke code. And in other hospitals with lower levels of stroke care, that wasn't necessarily true. And what we actually found was, if you were a CSC hospital, you were much more likely to detect a stroke than in non-CSC hospitals. There was no difference in outcome on any other metric. In fact, outcome was slightly better in the CSC hospitals compared to the hospitals here in blue that weren't comprehensive stroke centers. Why is this an issue? Well, first of all, we're probably missing some strokes that potentially could be treated. But secondly, stroke is actually a publicly reported quality measure, and it's used by CMS in thinking about hospital ratings. And we felt that that actually might hurt hospitals who are doing the right thing for their patients. Again, this is a central illustration from this paper, and after adjustment, the highest level of stroke care directly related to stroke risk. There was no difference in other outcomes, as I mentioned, and the level of expertise in stroke detection may explain some of these differences. So we felt, and this was published a couple of years ago, that stroke post-TAVR may be a poor discerning measure for quality. This analysis has now been repeated on a national level, and there is now a move afoot to remove stroke post-TAVR as a quality measure as it relates to TAVR. So over 10 years, Michigan has been able to improve quality and outcomes for all structural patients in Michigan. We're working to engage care teams individually. I'm meeting with care teams on a one-on-one basis virtually to go over their data. We're unblinding data at our national meetings, or our regional meetings. We're expanding to mitral and tricuspid interventions. We're evaluating appropriateness and hoping to control costs through doing that. In the future, we are going to be addressing disparities in access to structural heart care in our state. And we overall feel that we've informed quality improvement and outcome measures across the country and potentially around the world. So I'm just going to do a little conclusion for my part, and then Stan's going to jump in. So TAVR at Michigan Medicine is a collaborative program by design. It's a partnership between interventional cardiology, cardiac surgery, and our wonderful multidisciplinary team. We've got provide high volume clinical care. We do 25 new patient evaluations a week now. We've got a fantastic track record in research, over 500 patients enrolled in clinical trials. We're leading a statewide quality improvement program that does have international visibility. We continue to grow, but our growth is going to require more investment. We are landlocked. We've got one hybrid lab. We've got one cath lab that we use to do procedures, and we got more patients than rooms to do these procedures at this point. So we're working with leadership on a second hybrid lab to allow us more flexibility to do more cases and hire staff to do those cases as well. I believe that this program is a model of excellence. It demonstrates what collaboration, innovation, and commitment can accomplish. And I'm going to hand it over to Stan, who's going to take a step back, talk about evolving indications and new technologies in this space.
It's very difficult to follow the main act. So I feel like Jeff Beck following the Rolling Stones now. So I'll do my best. I see Kim here, and I would be very remiss before I dive into the meat of my talk. Dr. Eagle and directors at the time and continue to be big supporters of our program. We would not be where we are without the Icons Lab and other things that you've helped us achieve. And plus your foresight to have programs like MISHIC and all the registries in the state. So we might not say it every time, but thank you, Dr. Eagle. Really appreciate it. So I'm going to dive in. This is going to be a bit heavy with slides, but if TAVR is acceptable, we're going to say this is what we're going to do for our patients, and we're going to pay an investment. It has to be, for low-risk patients especially, it must be as good as TAVR. There's still a perception that we send patients for TAVR if they're not good for surgery above the age of 75 or 70 or 65. TAVR should be as good as surgery, and we'll look at some data. There are very few spaces in medicine that are so heavy data-driven. This is just from the first day we started. We went in an iterative fashion. We started with extreme risk, no options, high risk, intermediate, low, and then now we're pushing the envelope into patients with no symptoms. And you can see the plethora of studies, very heavy. Some of us made a career of being on these papers. That's why we got promoted. A lot of papers made from these studies. But if you look from Partner 1B all the way to early TAVR, we'll go over some of these. But very data-driven. And we also, we were doing this with surgery, but we also taught surgeons how to follow patients up with valvular disease. And the era of having things like a trifecta valve that might not work at 4 or 5 years may be a thing of the past, because we are now doing studies in the same way with long-term follow-up. But in the US, these are the two main companies, Medtronic and Edwards, that led us to where we are today. There were these major trials, extreme risk, high risk, intermediate, and low. There was some overlap because as we went from intermediate to low, the STS calculator changed, the surgeons got better, so some of these patients are overlapped. We are never supposed to and never should compare study to study. There are different studies with different patient populations. But these are the foundations of what we are today. And just to jump into the meat of it, we are now actually, we talk about low risk like it was yesterday. It's been 5 and 6 years already. And if you look at this is a partner study, we have to give a lot of credit to the partner investigators who went into spaces where we thought was not even safe or possible. And you look at this, there were 1,000 patients. One thing I will show you that many patients would game the system even during the whole journey of TAVR. They would come to do the randomized, and if they get randomized to TAVR, they would say, maybe go somewhere else and restart the process. Maybe I can flip the coin a couple of times, and go to a different study. But if you look at this in the end, at 5 years, we still have 91.6% of our patients available for primary endpoint at 1 year. When the study first came out at 1 year, we were ecstatic. TAVR was superior to surgery if you look at the data, but there's some things that happen, and we expected this. At 5, 6, 7, 8 years, we're going to see these curves either come together or even intersect. And that's something we're going to have to learn in the TAVR space, because do we need to modify leaflets more? Do we need to extract leaflets, even native leaflets? Do we try and mimic what surgeons do a bit better intraoperatively when we do a TAVR? And so at 5 years, the distinction is not as pronounced. There's also some creative way to look at these endpoints, and something called the win ratio. So if you look at these, we give a hierarchical system to, obviously the worst thing is death, and then comes disabling stroke, and then non-disabling stroke, and then rehospitalizations. You'd like to see the wins favor on one side, but not just go back and forth. So the first event determines if someone wins. If there's no event, you get a tie, and then you keep going down through the system. So if you look at the win ratio, there's 22.1% wins in TAVR, but the wins are mostly in rehospitalization. If you look at for TAVR, it's 19%. So if you look at this win ratio, what this really means at 1.17, that if you get a TAVR, looking all those hierarchical numbers from 1 to 4, you have a 17% chance of being better with TAVR, but not significant. So at least at 5 years, we're doing just as well. This is one we were very close to our heart, excuse the pun. We were actively involved and enrolled a lot in these patients, 66 sites across the US, Japan, and Australia, Canada, and Europe. 1-to-1 ratio from 2016 to 2019, we sort of overlapped into the dreaded COVID era. And for follow-up, especially if these become very difficult to follow up. And we're planning to do 10-year follow-ups. Never has valve studies been followed for 10 years. You look at this, Evolut versus surgeries, really good results for Evolut. It continued to be consistent at 3 years, 4 years, and then at 5 years, just like we saw in SAPIEN, we're starting to see these numbers come together. They still haven't crossed over. The big question is that what happens when a TAVR fails? reinterventions, are they more dangerous than surgical interventions? If you look at them between evolute and surgery, no significant difference between surgical reintervention or transcatheter reintervention. And then, especially with pioneering work that people like Shinichi Fukuhara have done here, the explant of a TAVR has become such more refined that in a lower intermediate risk patient, and this is data he's presented at STS and also at our meeting, the death rate for the mortality for a TAVR explant is not very different than a TAVR redo. One thing that Mike alluded to in the beginning of the Grossman is why we chose a supraannular valve for what we believe is superior hemodynamics, and this is proven here. We continue to see the superior hemodynamics all the way to 5 years and consistent, which is very reassuring. So that's why we think we can do TAVR in everybody. Going forward now, so we have TAVR as a accepted approach in a patient who's over 65, in whom there's a discussion with surgery and cardiology as one team with the patients and their families. So it's shared decision-making and a lifetime decision-making. Now let's move into more areas. Now let's become a bit more cocky. Let's move into spaces that we didn't think were possible before. Asymptomatic is one, and moderate AS, especially for our heart failure colleagues. If you have EF that's low and you have a moderate aortic stenosis, can you improve afterload, improve patients' management? So let me start with the first one, which is expand travel. This is asymptomatic patients, randomized in a 1-to-1 fashion, transfemoral versus clinical surveillance. One thing I wanted to show you in the next slide here is the importance of all of us in the office of doing a proper history taking. These were patients who were supposedly asymptomatic, yet 277 of them had symptoms. Labeled as asymptomatic, so you might not have even referred them to a TAVR clinic or a SAVR clinic, but when you actually do a detailed history taking with the patient and their family, you realize that actually their lifestyle has changed. There are obviously some anatomic exclusions, which we're not going to go into. If you look at the composite endpoint of death, unplanned hospitalization, or cardiovascular causes, there is a significant difference, but it's mostly driven by unplanned hospitalizations. And then if you look at the unplanned hospitalization, so we need to look at all the details of this. So we have to be careful not to rush in and sort of have an epidemic of asymptomatic AS be treated. If you look at these curves, after the first 6 months, they're really parallel curves. And in the first 6 months, many patients crossed over from the asymptomatic. So the problem with studies like this, we've seen this in the tricuspid domain as well, there is no sham control. So patients instinctively, if you have a device, you feel better. If you don't have a device, there's something more that can be done. And they know that if they go to the ER with symptoms, they can cross over to the TAVR arm. Now, I want to give credit for this slide and the previous one to Andrew Harris, who just last week gave a fantastic talk on this topic to our surgical colleagues. Here's the summary of all the early TAVR studies. You can see that it favors AVR in some various format, where recovery, avatar, evolved. This is not the scope of the study of this talk here to go over all of these, but you can see that there is some movement towards this. But it's not always been a victory in everything we've done. TAVR on load was something I felt was going to be even more significant than asymptomatic. It's an international multi-center trial presented by my friend who was here a couple of years ago, Nicholas Van Meegen. EF less than 50% and moderate AS by all criteria. You had to have guideline-directed medical therapy, or OHST as labeled here, or TAVR patch OHST, and we followed up in 1, 6, and 1 to 2 years. No different in MAZE, and again, you have a KCCQ quality of life improvement in the TAVR group. Whether this is a sham effect, a placebo effect, or a real effect, we need to see yet. Maybe mortality will see a difference in future years. At this point, I'd like to give a shout out. We have our own study continuing now in moderate AS. Andrew Harris, Dr. Harris, is our local PI. It's purely for moderate AS. You have to have class 2 heart failure symptoms and any of the documented heart failure event or some of these parameters, BNP over 600, GLS less than 15%, or EE prime of 14. So if you see any of these parameters in your studies, please refer to us. There is no patient we're not happy to see. It would be lovely. I know the APPs are looking at me like when I get mad in clinic, now they know it's your fault, not mine. So I apologize right now, but we need to see all these patients. Beyond moderate, this I think is also critically important and very important data that we need to share. Small aortic annuli. And because there's small aortic annuli, these are the studies that have a preponderance of women, which in many studies are underrepresented. And I'm going to focus mostly, here are the list of all the studies. And if you look at the SMART study, this is the first time we've had in this population a valve versus valve analysis. Here's the background, Evolut Pro, Pro Plus, which we've talked about today, the Sapien 3 Ultra. You look at the platform in the study, once porcine, again, Dr. Grossman explained these very, very well. And if you look at the outcomes of mortality, disabling stroke, or heart failure hospitalization at 2 years, they're more or less overlap with no significant difference. So very good. So we can do what we want to do. However, there are some signals that we need to be concerned about. For those of us who believe the hemodynamic story, this is where maybe we had something, maybe we knew something. If you look at things like prosthetic valve thrombosis, whether it's clinical or subclinical, one valve seems to be superior to the other. And any way you define these structural heart degeneration, BVD, and Dr. Grossman also alluded to some of these, if you have a gradient that's over 20, or non-structural valve, clinical valve thrombosis, endocarditis. And if you look by any definition, hemodynamic structural valve degeneration, non-structural valve degeneration, thrombosis, endocarditis, AV intervention. But the difference is significant between the two. It has not led to a mortality or clinical significance yet, but it's early, it's 2 years. I hope we won't see a difference, but the time is still coming. We have, as expected, superior hemodynamics with one valve, both from an EOA and a mean gradient. And at this point, I think we just wait with bated breath. It has always been our philosophy that we believe in optimal hemodynamics, both surgical. That's why Dr. Yang and Fukuhara have led this national drive to enlarge roots and give us the bigger valve. We believe in the same thing here. There's obviously other variables in the decision-making process, annulus, coronary heights, other things that will choose one valve versus the other, and re-intervention in coronaries. But at face value in a smaller valve, and this is a bit of an anecdote, we showed that we enrolled for 144 in Evolut studies or coil valve studies. The most study we underperformed was SMART, because we felt we knew the answer, and it felt, which is wrong, that it was ethically wrong to put a small valve in somebody, a 20 millimeter valve in somebody whose BSA was large. So we did not enroll as much in this. So new technologies. This is why I love this space. This is why I think the cath lab is the best place to be in, especially for up and coming physicians, because it is always exciting. But what do we look for in TAVR? We want to be able to have new technologies. We saw DASI, there's FIOBS, there's a plethora of AI and machine learning that will help us both plan and execute the valve. We need better valves with better durability. And we are planning for 20 years of life. So if we're implanting somebody in the 60s, we need 20 years of performance of this valve. The first thing we need to do is redo TAVR. Some of these TAVRs are now beginning to come back. And in the last 3 weeks, Mike, we've done like 6 or 7. We have 2 tomorrow. And we're going to use this technology tomorrow, just tomorrow, because we have concern that some of our leaflets will not allow us to put a second TAVR in. So we have either techniques called basilica, where you electrocauterize a wire, make it so you have a lasso in the ventricle, you come from the other side, electrify the wire, perforate the leaflet, lasso it, bring it up, use that wire electrified to tear the valve leaflet itself. So when you push it away, it does not occlude the coronaries, but then life becomes simple with this device. I can just go around. You have what is functionally a giant scissors that comes with TEE guidance and echo guidance and fluoro guidance. We position this directly in front of our coronary. You have a splitting element that is activated. Generation 2 of this is actually even better. It cuts calcium now. So one of what we're looking for now, and we are designing a study with Picardia, not only to cut leaflets in TAV and SAV or TAV and TAV, but to make a bicuspid valve tri-leaflet, cut it right through. And then also another area is this AI, aortic regurgitation. In guidelines, and that hasn't changed much, TAVI or TAVR is rarely feasible, and only in carefully selected patients with severe AR and heart failure who have prohibitive surgical risk. So what we sometimes in the lab call a Hail Mary. We're trying to do this, but we hope, and there's a lot of those eyes you saw in the first TAVR, what you see when we're doing an AI case or an LVAD case when we don't have these anchoring techniques. Why is AI difficult? multiple factors. They tend to have large aortic sinus and annuli, so they go beyond the sizing matrix we have for our TAVRs. They tend to have aortopathy and concomitant aortic dilatation. So not only but they need aortic surgery, but sometimes these aortas are verifiable and can give rise to aortic dissection as you pass the equipment. There's insufficient anchoring due to lack of calcium. And from a procedural standpoint, there's nothing to aim for. There's no calcium on the valve. You cannot really know where the annulus is. And because of so much AI, the imaging becomes very difficult. The TAVR migrates, you have residual AI and permanent pacemaker rates. Even in the surgical world, permanent pacemaker rates after TAVR surgery, after surgery for AI is higher. But luckily, innovation waits for no one. There's money to make in this, so you can see a plethora of studies. You have the Jena valve, the J valve, Hanker, and the cusp, which is basically a clip for the aortic leaflets. These two valves were bought by a company. I'm not going to talk too much about one versus the other. I unfortunately have been subpoenaed by the FTC because both companies were bought by one company, and somebody complained that there's a monopoly now. So on the 10th of October, I'm going to be 4 hours in a room with 15 lawyers. And it's going to be one of my joys of my life, talking about this. The Jena valve, we have chased chased this valve from its very inception. You can see there are special locators here that allows us to go into each sinus. There's these what looks like giant paper clips that allow us to attach to the leaflets. So you're not dependent on the annulus as much as we used to in the TAVR world, but we're actually dependent on the leaflets for positioning. And now, Mike, we have one tomorrow morning again, just so we're not sort of, and again, those of you who are interested, please come to the lab and see these cases being done tomorrow, because really every day this is real life. We used to have a long case with CTE and general anesthesia. These have now become routine TAVRs with fluoroscopic evaluation. And they're maybe 5 minutes longer than a regular TAVR. As we go forward, it's not just enough to show the device, but what data do we have? This is our first patient, first study we were actively involved here, presented by Raj Makar at ACC 25. We had the study itself and the registry, and two great things. We had let me go back here. You can see the success rate is very high from all these patients, and look at the hemodynamics. We were quoting great hemodynamics for the previous technology at 2.2, 2.3 effective orifice area. We're now looking at 2.8 and 2.9 with this technology. And gradients, generally these are adjudicated by core labs, not by us, at 4 or lower. And then you see why it's important to have dedicated TAVR valves for aortic regurgitation when you compare to off-label THVs, and there's a plethora of them here, different Sapiens, Navitor, this is the old Accurate and Evolute. You can see how success rate is higher. The need for a second valve is higher if you use off-label valves. So this is very important. And I am waiting with bated breath because any day now, hopefully, we'll have approval by the FDA. Because we anticipate approval, because we've seen the results and the data has been presented to the FDA already, we now have the ARTIST trial moving again, just like we did for TAVR and AS, into the moderate and low risk subgroups. And you can see this is the design of a low risk study. And then very important to us and our heart failure colleagues is the Siena VAD registry, which is nested within the AR study. It's 10 centers, and we're lucky and privileged to be one of these 10 centers because of our also reputation in the VAD domain. And basically, there has to be a rigorous inclusion criteria, but this is going to be a significant game changer for us in the patients who have AR in the LVAD domain. Brad, I hope that makes you happy. So, just some using in the end, so some sort of my thoughts. If I were designing, if I had sort of power to design the ideal aortic valve, it needs to be durable. It has to have optimal performance in inception and long term. There needs to be minimal interference with surrounding structures. It needs to be simple, predictable deployment. You need to democratize the implant. It cannot just be in high volume centers. There needs to be low complication rates, absolutely low complication rates, and a low profile for transfemoral delivery. You think the TAVR story is done? It's not. There are some really interesting concepts coming out. You can see the Seagull, Optimum, Dura AVR, and Foldex, and I'll go over two of these. This is a really unbelievable shift. We've used chromium carbide or stainless steel. Seagull was a patient, and this is a known story at Cleveland Clinic. He talked to the designer of this valve. and said, and Siegel also owned 50% of US Steel. And when they were talking about something else, he goes, you should talk to my metallurgist at the company. So they went, and when they asked him, like, what do you use? No, we use chromium, cobalt, we use titanium. He goes, you're using the wrong metal. It's molybdenum rhenium is the metal you used to use. It's the most radial force. It does not, it conforms the best. So if you look at when you implant, this is what we use our Edwards systems. There's 12 rows of cells, 4 rows of cells, 12 cells per row. The superannular valve is even worse, 15 cells per row and 9 rows. Because of the way this metal is designed, you only have 9 cells per row and 9 cells per row and only 2 rows. So less crimp profile, increased coronary access, less foreshortening. So you know what you see is what you get when you implant this. You can have symmetrical expansion, and you can also align the coronaries. But in plain English, what this is important is that whereas these are put in through 14, 16, or 14, 16 sheets, this is now an 8 French system. We can joke, but maybe in the future we'll have radial TAVI. If you go forward, this is a newer design. This is Dura AVR, a new class of TAVR. This is designed by surgeons, a single native-shaped biomimetic design built to mimic the performance of a healthy aortic valve. So whereas the other valves have 3 separate leaflets sewn on, this is one circular device. You can see that there's all these features about it. Again, commissure alignment we feel is very important, not just for the initial implant, but for the second TAVI, so you don't occlude the coronaries. And then similar, again, important, not like Jena, but similar hemodynamics to a superannular valve. So very interesting. These are in small annuli, but they give you numbers that are consistent with a superannular valve, and you have great performance even in low annuli. You see from an engineering and flow dynamics that this valve allows you, once implanted, and please don't ask me what these mean, but they're supposed to be that the healthy control looks very much like a Dura AVR. So the flows are consistent with what evolution or God gave us in the aortic valve. So the future, there's going to be alternative materials. So there's going to be a new tissue process. There's tissue-based biomaterial. There's going to be a synthetic permanent polymer. All these are in different processes of development. We're going to have biodegradable polymer in situ with tissue engineering. And then the holy grail is the regenerative material tissue engineered valve that will be your tissue in your own valve performed. So some of my final thoughts more than a conclusion. I've used this before. The journey has been very exciting. I hope that Mike, Himanshu, and the other Mike and I can sit down someday here like a fireside chat and go to some of the funny stories we had. We nearly died in Portugal, so there would be no TAVR story in Michigan. We're dying in a cab of a crazy cab driver. There are many unanswered questions that we have to investigate and learn from, and not rest on our laurels. Always go back and see what we've done, where we're doing it right. We are embarking also very exciting on a very similar journeys in the mitral and tricuspid space. And in the words of Winston Churchill of the Battle of El Alamein, this is not the end or the beginning of the end, but it's the end of the beginning. The best is still yet to come. And for those young doctors in this room and everybody in this room, it is exciting. My only regret is that I'm too old to see the end of this, because it is just so exciting. And thank you for your attention.
Thank you so much, Dr. Grossman, Dr. Chetcuti. That was a fantastic talk. We'll open up the audience for any questions. Just push your button, it'll turn green. Talk for questions.
Do you have the chat function on your computer to see?
Mike and Stan, I think obviously your presentation bespeaks the courage of you and your entire team. And I think it reflects also passion to get something done when an institution is reticent to invest sometimes. You know, we had to pay for the TAVR valves and we were being told this is a money loser, and now look at it. And your courage to take this on and passion to stay here and see it through is really, really remarkable. What my question to you is, what are 3 things that would make us the best valve and structural heart program in the world that we don't currently have?
I mean, I could, from a mundane level, I genuinely have nightmares. We have one lab, it's end of life. we need a second hybrid. But we also need to have the ability to move quickly. A CTSU that is helpful, keeps us honest, but is too pedantic and slow. IRB is better. And so I might get in trouble for saying these things out loud, but people know me forever. I'm the guy who, when the emperor is wearing our clothes, I say it, even though you can all see that he's naked. But I'm going to say it. Our CTSU is too. We can be doing first in man and being the partner for industry to be leading innovation in this institution. And then something we didn't mention so much, but I think is going to be changing, is the concept of machine learning and AI, both for predicting and implant technique. And many of these new procedures, it is like being in a gamer's room. I have implanted valves in the mitral and tricuspid space technically with a joystick from a PlayStation joystick. So you're playing from your bedside. So we need those things. We need partnership with biomedical engineering, partnership with industry, and be more flexible.
Yeah,
Thank you.
I just,
Mark.
our team is fantastic, but they can only do so much. So we need to invest in our team in clinic, our research team. And then post-procedure, the ideal care for these patients is by a team in one location that has experience taking care of them. Right now, our patients go to 3 to 4 different areas within the hospital post-TAVR. And it's not fair to expect the nurses in those areas to know what to do and what to look out for with some of these patients. So at one time, all of our patients went to CVC5, and we worked very closely with that team to improve the care. So with the new tower, we would really, if our patients are going to go there, we've got to find a way that we can work with the staff there to streamline care, improve care, and make sure that the patients are getting optimal care and then discharged in an efficient way.
If I could make one more comment. I want to thank Dr. Pinsky too, because you mentioned that the institution did not let us buy valves when they became commercially available. And Dr. Pinsky in the Department of Medicine, you might remember, David, I'm sorry if I'm sharing something that's confidential. Department of Medicine bought the first 10 valves for us, not the hospital. And that's how we were able to implant. And that's thanks to you, David. We would not been able to do it. The other thing is the institution still has, and I wish David Miller was here, silo concepts. You have UMMG takes care of echo and outpatient stuff and this. So instead of having a horizontal integration, we have vertical integration. So for example, on a Saturday, we used to do 2 TAVRs and we're happy, and we do 4 TAVRs and we're happy. Now we're doing 6 TAVRs every week. But the echo support for TAVR from the echo techs, because somebody said there's no overtime allowed, we lose our echo techs at 4 o'clock. So at 4 o'clock or 5:30 sometimes, I have to break scrub, or Dr. Grossman break scrub, and go back 30 years and see if I can do a personal long axis view or get an apical 3-chamber view. It is pathetic that this happens in this institution.
In Stan and I
Yeah.
Other questions? Yeah, we don't want to air the dirty laundry of our program because we could not be in a better place. Our program has grown tremendously. I couldn't be more proud of all of our team members. We actually are in such a much better place than we've ever been.
We are. And just to give kudos to everyone, again, Troy has been super supportive. The Echo Lab has been super supportive. The text, it's not from the text standpoint, it's just some, but we also have to credit the institution and all of you. Our volume this year is up 20%. We are growing in leaps and bounds, and our team is working really hard. Plus, our team also does inpatient consults, as you know. So these are all things, we are really in a very good place. We have right now, Michelet, how many structural studies going on? 16? TAVR and mitral tricuspid. 17 active studies. We're one site in the US that has 5 mitral replacement technology, 6 now, 3 tricuspid replacement technologies. We're going to have Dura, AVR, and Siegel. So we could not be happier with the team, with where we're working here. And my regret, as I said before, is I'm getting too old, and I feel like I'm in the twilight of my career, but I wish I had 20 more years. David.
So just give yourself a valve, you'll get 20. I just want to compliment. I have one question, but really, this is an awesome team. I mean, I've had the privilege of watching it evolve. You know, I have the privilege because of where my office is located to watch the huddles that go on just, you know, a few doors down. And I really love the team approach. It's just remarkable. And I think we at Michigan are already best in class, but then Kim's question is my question. We want to be bester than best. And how do we do that?
So I guess one other comment, and this may be slightly controversial, but I think every patient with aortic valve disease over the age of 60 should be seen in the multidisciplinary clinic. They should hear about all their options. They should hear about their future. It's a bizarre paradox, but at least in this state, and I think around the country, cardiologists don't refer to cardiologists. So we have our own former fellows referring to our cardiac surgeons to evaluate them for TAVR, rather than referring to our multidisciplinary TAVR clinic. So we need to work on that as a group with our surgeons, with our call center, to figure out a way how that we can get these patients the information they need to make the best decisions for themselves and inform them about not just what we're going to do today or tomorrow, but what may happen in 10 or 15 years. So that to me is a way also that we can even move the needle and move forward even more.
That's fabulous. Can I ask just one real question? Is with so many trials that you're running, how do they not compete and conflict? I know in the cancer world, they have fewer so that they can streamline it, but you've got so many.
So many of these studies have different criteria. Some of these devices don't overlap in where and how we can use them. Sometimes it's political to have two studies from two different companies because each company gets some new toy in the near future. So you want to still be in the game with every company. So where there truly is a conflict of enrollment between one study or the other, first of all, patients always know that we have two conflicting studies. And then if it's up to us, we with the IRB and Allison, we've used things like birth dates, odd or even. So odd goes to one side, even goes to the other side. And then if it's leaning more towards one, then you flip over. Or we've used social security numbers. There's ways to make it fair that it's.
All right. Well, in the interest of time, thank you again very, very much. This was a wonderful, eye-opening talk for how our TAVR program is doing. Thank you so much.
Thank you.